I thought I would entitle it Past, Present and Future. Firstly, thanks for coming, by the way. Believe it or not, I saw my first patient with PSC when I was a very lowly registrar in Southampton General Hospital in 1975. And this is 40 years now, 40th anniversary. So went to the books, and there was actually nothing at all about PSC. So that's how it sort of started, really. So I thought I wanted to study it. Before we go on, just to note, that's just how it's currently defined. It's a progressive, usually progressive, not always, I'm glad to say, progressive disease of the biliary tree, when you get this scarring and stricturing of the bile ducts, which can, in not everybody, but in a lot of people, progress to end-stage liver disease. And as Martin said, it's getting a huge amount of publicity at the moment. It's become flavour of the month after 40 years, with a lot of big pharma, with research institutions and everything else. So it's really a great time, I think, for PSC research and people with PSC. It really is. Michael Manns is a guy I know well. He's a very famous German professor of hepatology. Described it as a quote which has stuck, really, as the last black box in hepatology. Just to put that into context, hepatitis C, which obviously is a very common liver disease, has been cured by a tablet. So one tablet a day now, from now on, for people with hepatitis C, will cure 99% of people with hepatitis C. Just extraordinary. And that's been done over 20 years. So then when that's done, pharma moves it out a bit, and the searchlight shines on something else. And I'm glad to say the searchlight has alighted on PSC. And it's really good times, I think. Again. So this was my mentor, actually, a lady called Sheila Sherlock, and I went along in 1976 to see her, and I said I wanted to work with her and do a PhD in liver disease. So I went into her office, and she was a huge giantess of a hepatologist, the first sort of woman hepatologist in the world, really. And I went in, and she was marking exam papers. She didn't even look up from the desk. And so I went in and she said, "What do you want to do?" And I said, "I want to do PSC." So she let me roll on for about 20 minutes. And then she said, "There's nothing in that." She said, "You're doing iron." Which meant I was doing hemochromatosis. So anyway, I said, "Okay, well, thank you very much." She said, "I'll see you in 6 weeks." And that was it. So I turned up and I did iron. I did my PhD actually in iron metabolism, not in PSC. However, she let me do the PSC, so we published our first paper on PSC in 1979, and that's what we thought about it in just how times have changed, really. And this is an old American slide from that time. Go back, the wrong way. Wrong way. Sorry. Get back in a minute. There we are. Good. From 1979. We thought that people were male patients, and that time there were less than 100 patients described in the whole world in 1979. So it does, how things move on. Now we have 2,200 patients in the British cohort. A recent immunochip study, we had over 4,000 patients included in that. So you think that's really quite a lot of progress in a reasonably short amount of time. So over 40 years we've gone from this patient. Then it was thought to have a terrible prognosis, because the patients who actually were diagnosed, you couldn't diagnose it. There was no way of diagnosing it at that time. We couldn't do cholangiography. And it was thought to be a terrible diagnosis. Thought they were young men, lots of pain, lots of fever and sweating. That's not a cigarette, because as you know, you're a group of non-smokers. That's a thermometer. And he's old-fashioned thermometer, and he's grasping his liver because of pain. And he's got absolutely rip-roaring colitis. And almost everything in that slide is incorrect. And that just shows how things move on on a 40-year basis. So why is it incorrect? Well, we now know that most patients with PSC who present are actually asymptomatic. And in the Oxford cohort, we have over 360 patients in our database. The majority of patients have no symptoms. And I picked up usually by a sharp-eyed registrar in the colitis clinic who notices that liver function tests are abnormal. So despite the name of the disease, cholangitis, which means a fever, infection arising from the bile ducts, that is extraordinarily rare, acute cholangitis, I'm glad to say. And usually it used to occur after instrumentation. It doesn't occur so much now. So the majority of patients are not sick and ill. As you know yourselves, you're pretty well most for a lot of the time, and that's very good. And so in our hands, 60% of our patients are asymptomatic. So quite a complete change in spectrum. Now, the other thing that's changed, which is great news, is that if you look at the internet, you'll see that the average survival before a liver transplant is 12 years. Now, we also know very recently that's absolutely not true. This is data from the Dutch cohort published 2 years ago from a mate of mine, Cyril Poinsonen, and their median survival of all comers, everybody, is 22 years. So we've gone double in the survival. Our survival in Oxford is 24 years of all comers. Recent study from Israel, 24 years. So quite clearly, the spectrum has changed now, so people are doing much better than it used to be. So when you go on the internet and you see all this doom and gloom, those are the figures. And what you may say, well, why did you get it wrong? Why did you think it was 12 years? Well, the answer, I'm not sure if it's shown in this slide, it's not shown on that slide, is actually that the data all arose from transplant centres. So people who go to transplant centres usually are reaching a severe stage in their disease, so that's why it got so skewed. So when people are referred with, how do you make a diagnosis of PSC? And this is basically, you have these abnormal biochemistry, which I mentioned, usually a so-called alkaline phosphatase, which is an enzyme in the blood which arises from the bile ducts, is elevated. There is an antibody, which is not specific, and there is this thing called IgG4, which it become a sort of particular interest of mine as well, but we won't go into that today unless you want to. IgG4 is quite even rarer than PSC, and most of us thought it didn't exist 10, 15 years ago. But we now have over 100, about 95 patients in Oxford with it, gathered over a 6-year period. So this is a diagnosis and a disease which was missed by everybody in the West, and then a lot of researchers in Japan kept talking about it. People like me kept saying the papers back saying it's rubbish, and we were absolutely wrong. It's a definite condition which exists, and it overlaps with PSC and gives a very similar picture of PSC in many ways. But it's treated differently, it behaves differently, and it's very important then that the doctors looking after people with PSC make sure that it is PSC and not IgG4 disease. And that's become an important part of our research as well. Now, the diagnosis then rests on a cholangiogram. It used to be a terrible thing called an ERCP, which some of you may have had, where you had an endoscopy and you had a tube into your bile ducts, and they took some pictures. I did 10,000 of them in my career. But the problem with it is it causes complications. It can cause pancreatitis, it can cause bleeding, it can cause infection. So then what really the big breakthrough is, as you all know, is MRCP, which came along about 10 years ago now, and enables us all to get wonderful pictures. They get better every year, the software gets better, and the pictures are absolutely fantastic. So really, there are 1 or 2 patients who haven't needed an ERCP if the MRCP is inconclusive, because it is important to get the diagnosis correct. And you will go find some places in Europe, believe it or not, where they do ERCPs every year on all their patients. If you happen to go to Finland, or if you happen to go to Heidelberg in Germany, they will do an ERCP every year on everybody. But that's really not important. So liver biopsy. Well, liver biopsy, you'd probably be glad to know, is really passed out of the diagnostic spectrum. So you will, I suspect, looking at the smiles, that some of you in the audience will have had a liver biopsy over time. By and large, it's only required in 2 sort of specialist situations when you're suspecting a condition called small duct PSC, which I'll come back to, an overlap with autoimmune hepatitis, and perhaps also in there I could add IgG4 disease as well if you suspect that. So those are the rare indications. But as you'll hear at the moment, from Kate Williamson comes along, who's one of my research fellows, she will tell you that most of the studies these days require liver biopsies to show that the drugs that they're looking at need benefit. So we have this quandrum, if you like, is we don't need a liver biopsy for a diagnosis, but we may need it for research purposes at the moment. So that's the sort of the dilemma that we have and you may have as well as a patient group. And so I'm sure we'll discuss that later on as we go. So what about 2020? I started in 1976. What about just in 5 years' time? Well, I think things are changing. Clearly, MRCP will be important, but we now are coming along very important serum markers of fibrosis. We'll be able to tell from a blood test, and this is already, technology is already around, be able to tell from a blood test how severe the scarring of the liver is, which is a great step forward, really. And in the past, we'll be able to do a liver biopsy only to tell us that. Now it'll be a blood test. There's great new non-invasive imaging coming along, as you probably guess. There's a FibroScan, which is a special way some of you may have had that, where it's like an ultrasound machine, and they do it does a sound wave through the liver, and from the echo reflection of the sound wave, you get a measure of the elasticity and the scar tissue within the liver. That's been widely looked at, and we're not quite sure how good that is in PSC, but there's a great multi-center trial going on in Europe, which we're going to take part in, hopefully, which will help answer it. There's MRE, which is magnetic resonance elastography. Again, it's an American technique, comes from the Mayo Clinic. I'm just reviewing a paper as we speak from the Mayo Clinic showing good results in PSC using this technique. And then there's a technique, I'll declare an interest here. There's an Oxford spin-off company called Perspectum Diagnostics. I'm not actually on part of the company, but I'm an advisor to the company. And there's a thing called MR Multiscan, which I'll show you, which also has great potential for measuring scar tissue and damage. So what it means is, instead of having a biopsy, you'll probably have a scan, go in, have some form of scan in 5 years' time, which will give a lot more information than we get now. So that's real progress, and that's not far away. That's almost with us, I think. So this is the parametric scan here. This is taken from this. This is the sort of scan you get, pretty colours, and just to show that basically, I expect to see this. So this is the spleen, big spleen. This is the liver here, and the green is bad and red is good on this particular slide. But you can get some measure from that. You can actually measure the amount of iron, the amount of fat, the amount of inflammation and scar tissue from this simple scan, which adds 5 minutes to an MR scan. So you have your MR scan, same scanner, bit of clever software, and you get some very important information. And this is, again, where it's being evolved, it's improving, and is available as we speak. And this is a patient who had PSC and overlap with AIH. So what it enables us to do, again, is but this is just a slide to show how accurate it is. So if you look at the liver fibrosis score as opposed to the liver, from a liver biopsy compared with a scan, you get really very accurate figures as to the amount of scar tissue there is in the liver. And that was published last year in the Journal of Hepatology. So really, again, major progress in scanning, you'd be glad to know. Another thing that's come along is something that I realized some years ago, which I think is turning out to be correct, that what we call PSC probably isn't just one disease. It's probably at least 3 separate conditions, perhaps more than that. The main one which we talk about as PSC is PSC associated with inflammatory bowel disease. I've mentioned IgG4, which probably makes up about 5% of what we thought was PSC in the past. And there's another thing which I've called here PSC non-IBD associated, about 50% of patients. So these are patients who will never develop inflammatory bowel disease. And why it's important is it looks like they have different genetics, they behave differently, and therefore it means we're able to target our treatments at the specific sorts of patients who need it. So these are the sort of, we call it phenotypes, the sort of conditions you have. And we know that there are a number of phenotypes, so they're males or females, obviously. Whether you have involvement of the bile ducts involving just the liver, or the liver in the bile ducts outside the liver as well. Features of overlap, the type of inflammatory bowel disease, presence of IgG4, small duct disease as opposed to large duct disease. And all this, people behave differently depending on what type they have. We call that clinical phenotypes. So that's important as it comes to biopsies. And just to show that, no, I'll leave that slide, I think. Now, again, this is a slide I may have shown before, but it's just interesting that really, that if you happen to be a lady, in our group, this is Oxford data, a lady looking at these patients over time who may require liver transplant, if you don't happen to have inflammatory bowel disease and you're a female in Oxford, you'll notice that you do extraordinarily well. I won't say who's in the audience who fills in that group, but there are people in that group who are in that group. So actually, that happened from seeing Linda year after year, sitting on the front row looking very well. That's absolutely true. It inspired me to go back and say, look, maybe there's a different disease here. Now, we've obviously gone back and looked at the genetics as well, and they're different. So, and this really, I think, is a condition which is a very benign condition, which probably doesn't require any treatment at all. And therefore, it's important that people like Linda, if you like, don't go into clinical trials because they don't need to. But that's important to realise that. I'll leave that. So just looking back at our IBD in Oxford, so inflammatory bowel disease, 20% of our patients don't have inflammatory bowel disease, and the majority of them, though, do have either Crohn's disease or the majority have what's been called ulcerative colitis. So what's been interesting, I'm sure again you all know this, but just to say, if you happen to have ulcerative colitis and PSC, you have a very different type of disease to people who don't have PSC. The disease is predominantly male, which is not normally the male-female is equal. It involves the whole colon, but very mild symptomatically. So you have far less relapses, far less severe attacks than you would if you don't have PSC. So it's a milder form of bowel disease. The rectum, the last bit of the colon, is spared, actually in our hands, 40% of the time. So if you just have a look at the rectum, you'll miss the fact that the colon is involved. And that's not true in ulcerative colitis either. I'll leave that. And also what we call the associations of the conditions are quite different with PSC. So really, that gives you a clue that it may be a different condition. I'll leave that. No, just to say, basically, we looked at our Crohn's disease versus our non-ulcerative colitis patients, and if you happen to have PSC Crohn's disease, that has a wonderfully good prognosis in our hands. So it depends a lot on whether you have ulcerative colitis or what's been called Crohn's disease. So what we can do now is we can begin, when you sit in front of us in the clinic, we can get some idea from all these sort of things how you're likely to do without treatment. And hopefully, as I say, we'll be able to target the treatments, but I'll tell you about later on, to the right sort of person as we go. I'll leave that. So what has that led to? It's led us to believe, which has now become accepted, I think, by the IBD community, that PSC IBD is a separate, distinct disease from ulcerative colitis or Crohn's disease. It's a disease in its own right. It's all part of the same condition, but behaves differently to other forms of inflammatory bowel disease. Why is that important for you guys? Because it means that the pharma is interested. Pharmaceutical companies are interested in this type of association, and again, interested in putting money into it. Just a word about small duct PSC. That's a condition whereby, usually inflammatory bowel disease, again, you have a normal cholangiogram, but you have a cholestatic liver function test, and you have an abnormal liver biopsy. And that's common in females than males, particularly common in Crohn's colitis, and it has a very, very good prognosis again. Okay, so this is the small duct and the large duct over time, and only about 20% of patients with small duct will progress to large duct. And if you stay as a small duct PSC, you have a completely normal lifespan. Will do extraordinarily well. So again, you don't need to be treated. So I'll leave that. I think it just shows also it's a study which we did actually with small duct PSC, a recent study from we combined our data with the Norwegian group, and we showed again that with small duct PSC different genetics as well. So these are different genetic diseases in that group of patients. So they're we're able now all the time separating out these subgroups of patients. Now, just in the past, I spent literally, you need to look at this slide, it just shows the various studies from Oslo, King's, Hanover, Sweden, Mayo Clinic, trying to find ways of telling us in the clinic, when we first see you, how you're going to do in terms of your prognosis over time. And we tried all sorts of fancy models. These are all the things we put in, the liver function test, finding a big liver, small liver, whether you'd had, how bad the biopsy was, and none of that really, all derived very complicated formulas to say how long the prognosis was going to be in terms of needing a transplant or whatever. And none of these worked. They were very complicated, and they didn't transport. So if you did it in America at the Mayo Clinic in Minnesota, when you applied their model in Oxford or in Norway, it didn't work. So clearly these models were really not very successful. And what's been amazing, is that the height of the alkaline phosphatase after the first year of treatment has become a very important biomarker. And I pinched this idea from pulmonary biliary cirrhosis, whereby you know that if at the end of a year that you normalize or almost normalize your serum alkaline phosphatase, you will do exceedingly well. And that's whether you have URSA or not. And this is basically, again, if the alkaline phosphatase is normal, or almost normal at the end of a year, this is our data shown down here. There's been 2 more studies since confirming it. And amazingly, just the measure of the alkaline phosphatase, very simple blood test at the end of the year, will say how you're likely to do in terms of treatment. So I'll leave that, leave that. So I'm just talking through, I'll leave that too. So just basically, these are the guidelines. There are new guidelines coming out, but we're very careful because there is, as you know, the increased risk of various forms of cancer in PSC. So this is what hopefully you'll be offered in your centre. I don't think the new guidelines coming out are going to say anything different. I have read them. So basically, if you certainly have ulcerative colitis and PSC, you should be having a yearly colonoscopy. And you should almost certainly be having what's called dye spray as well, which means that the colonoscopist puts dye into the colon and picks up areas which we may not see naked eye with the colonoscopy, which will be perhaps show precancerous lesions. You're trying to pick up precancerous lesions. And if you do, then we take the colon out. So if you don't have IBD, how often should you have a colonoscopy? It's not evidence-based, but probably every 5 years you need to have a colonoscopy. You need a yearly ultrasound of your gallbladder. This is not working very well, so I'll use this. And there's been a question about whether you should have a yearly MRCP. You can imagine that MRCP is limited by time and money. And the evidence, such as it is, from Australia, from Perth, is that it is not worth having a yearly MRCP. It doesn't seem to be beneficial. There are studies going on in the Mayo Clinic. If you read the Mayo Clinic guidelines from the Mayo Clinic in PSC, they will recommend a yearly MRCP, but it really is not evidence-based. And I don't think at the moment we have any grounds at all. People say, why am I having a yearly MRCP? Well, the answer is the evidence doesn't show that you need one. It doesn't pick up anything on a routine basis that needs to be done. So that's both true of both the American and the EASL guidelines. So actually the good news again for you is that if you have Crohn's disease, certainly in Oxford and also in Denmark and also in the current European study, I've seen the data, there's really, it looks like if you have Crohn's disease as your sort of type of inflammatory bowel disease, there's a much less chance of developing a dysplasia and cancer in the colon, which is good news also. Again, not really recognised yet. And if you have Crohn's disease, how often you should have a colonoscopy, I think, is probably about every 2 to 5, within 2 to 5 years. But that's, I think, will be in the new guidelines. So if you have Crohn's disease as your type of inflammatory bowel disease, a colonoscopy less often. That's not agreed yet, but I think it's probably true in the data that we've seen. Again, what will happen about trying to find bile duct cancer in 2020? Well, again, the good news is there are new biomarkers coming along. So these are ways of looking at the urine and looking at proteins in the urine and proteins in the blood, which will be able to say not that you do have a cancer, but might get one. In that case, you can have a prophylactic treatment. So that's exciting. And also, I think these new scanning techniques also would be useful. So I think on balance, that again looks very exciting in the next couple of years. Management, we know, is complicated at PSC. It requires liver doctors. It requires inflammatory bowel disease doctors. It needs endoscopists. We did all of that. We did all of that here, but together. But by and large, you need to have a team of specialists looking after you, which is why I think, as we say, I think it should be in a centre which is used to looking after people with PSC. And there are 3 basic management. Firstly is giving specific medical therapy. The second is managing the complications which occur in the bile ducts, usually endoscopically by doing an endoscope, and eventually, if appropriate, referring for a liver transplant at the right time. And that's really where it's quite a skill, because in some liver diseases that's quite easy to do, not so easy in PSC. So the aims of therapy, as you said, Linda, the aim is to cure the disease, to prevent disease progression, to prevent the risk of cancer, and both in the colon and in the bile ducts. And that's what we're striving to do. Now, we don't do terribly well any of those things yet, but it's coming along. And I'm sure, I've no doubt it will improve better. I'll briefly say this is the past medical therapy. Whenever you see a long list of therapy, it means things don't work very well. And just to say, because it's a disease of non-smokers, people have actually tried giving you guys nicotine, okay? Both in the form of enemas, believe it or not. Nicotine enemas, think about it, and also nicotine tablets. But again, that was unsuccessful. You're probably glad to know it was unsuccessful. People do ask me, usually these things, should I smoke? And the answer is no, you shouldn't. Well, if you want to ask that again, but there's no real evidence that the smoking helps, although it is a disease of non-smokers. Now, primary biliary cirrhosis, very similar disease of females, but quite different disease. That's a disease of smokers. So it's really quite a different etiology. So the results of all these things have been pretty disappointing, really. We use steroids in people who have overlap. So if you're on steroids, that's probably why. But we don't use steroids routinely at the moment unless you have IgG4 disease, separate condition, or autoimmune disease overlap. Other than that, steroids are not really very helpful. And some of you may have had things like infliximab, biological therapy for colitis. Again, so far the results have been disappointing, although people are now looking at that again. So why have we been so bad in the trials? Well, the trials it's been rare condition, underpowered, because of, as I've been alluded to, people have been going into the trials to have a very good prognosis, which will screw the results. We've had no good surrogate endpoints. So what does that mean? Well, if you have a condition which it takes 22 years to go from when you present to needing a liver transplant, 22 years is certainly almost a doctor's lifetime. So it is not conceivable you can do clinical trials that last 22 years. So you have to do what's called surrogate markers. So a marker which will tell the doctor that the treatment is working. And it's been a really very difficult area in PSC. And so basically most of the trials at the moment, as Kate will tell you in a moment, still require a liver biopsy. New trials coming along, and there are lots of them. They require liver biopsies. Now the good news is we're having a meeting at the end of August with the FDA in Washington. They're paying for it, and we're going along, and 4 of us are helping to organize it. And part of that meeting, well, the whole purpose of the meeting is to find surrogate endpoints, which means that you can do clinical trials because of all these new drugs, but you won't need to have, for example, liver biopsy. So surrogate endpoints is where it's at the moment. And it's been in the past been underfunded by pharma, but that's changing. I'll leave Sarah, I mentioned that. Now, we also get asked about URSO. URSO, obviously, as increases bile, theoretically should be very good. It washes out toxic bile acids. It increases bile flow, which is good. It has a good effect on the immunology. It decreases HLA expression, which means that the cells are less likely to be attacked by lymphocytes. And it decreases the normal cell death in the bile ducts and the colon. So really it should be useful. And there was one initial trial, it wasn't very helpful, but there was a trial from Scandinavia which wasn't significant but did show a benefit of placebo in this dose, which led to a high-dose trial in America, which you'll probably all know about, which showed, surprisingly, multi-center trial in America, a high dose of URSO, and the patients on the URSO, high dose of URSO, which we wouldn't use, did worse than placebo. So the trial was stopped. So there were increased deaths and transplantation in the URSO group compared to placebo, which set the cat among the pigeons. I still believe actually probably this was a rogue trial, but what it meant was that we can't give this sort of dose for of URSO. It also led to a lot of confusion, as I've shown you this slide before. So by and large, bile acid, the Mayo Clinic particularly led the charge to say that URSO is not indicated for the treatment of PSC. And you'll notice that I'm first author on the American guidelines, and I didn't actually write that. I think I said before, what I actually wrote was high-dose URSO is not indicated for the treatment of PSC. The senior author, a friend of mine, still is surprisingly, in the proof stage took out the words high dose, leaving that. Now, he still believes very much that URSO is not indicated for the treatment of PSC, but actually doctors in America still use it, and it's particularly in the pediatric population otherwise, and it's still very widely used in Europe. I think probably with some justification, which I'll come to. So anyway, that's what I wrote on that. Then if you look at the European guidelines, which also I was contributing to, then they were indicated. We felt they were indicated. And this just shows our data, which is interesting data, and I thought you'd like to see that. Unpublished, I think. So we looked at, again, like PBC, we looked at people who received URSO and who responded to the URSO at a year. So at the end of a year, liver function tests normalized on the URSO. And if they normalized, again, a very good prognosis. And probably, I reckon, about 35% of people with PSC will respond to URSO. Now, this is not a universally held view. It's my view. It's particularly my view. But I think, a bit like PBC, some of you will do okay on URSO. Not the majority of you, but some of you will do okay on URSO. I think URSO still has a point. The other point is that there are 2 recent studies from America, again, once the Mayo Clinic, showing that probably URSO may be protective against colon cancer as well. So I still believe that's in low dose, actually. So I still believe that probably at the moment, until these other things come through, URSO still is the best we've got, and you should probably be on it as well. So that, despite what the American guidelines say. So where will we be in 2020? I think we may well be using low-dose URSO to protect your colon and have some benefit. So I think we'll be looking at other treatments. I'll come back to that. So in terms of other treatments, We know that PSC is genetic. There are a strong number of genes involved. This is a gene which involves the composition of the bacteria in the colon. These are immune genes and obviously male gender. We know that various environmental things, smoking does protect. Coffee protects. That may be better news for you. Probably 2 studies have shown that, and actually, generally speaking, across all liver disease, coffee is an anti-scar tissue. I love coffee, so I can say that with some benefit. And there probably is maybe an infectious trigger. Now, what the biome is a huge area of research at the moment in inflammatory bowel disease and in liver disease. The biome are the trillions of bacteria you have in your colon, and they've even been called an organ in their own right. It seems very likely that people who are genetically predisposed to get PSC will have a combination of bacteria in their colon which trigger it off. That seems to be very likely as to what it is. So therefore, and that's true of inflammatory bowel disease as well. And so it looks like that the research is going to be over the next 5 or 10 years looking very much about people with PSC. Do you have different bacteria to people who don't have PSC? Types of bacteria. And I think the answer to that will be yes. There's a bit of evidence already to suggest that. So I think the future will probably be manipulation of the immune system and manipulation also of the bacteria in the colon. That's speculation, but I think that's what we'll be in 5 years, 10 years time. And a lot of money going into research into the biome. So I'll just come back to money and funding. Before I mention that, I met a nice lady from America this week, who you'll know, whose brother has got PSC, and she's rather dramatically called the thing Save John. Is that right? I think. Anyway, it's a dramatic title. Well, what she's doing is she's a doctor, and she's given up her career to find a cure for her brother with PSC, and she's looking at raising $20 million into PSC. Now, we already have from Norway. We have 40 million euros, and the Norwegian government have recently just added to that, so they kept that going because it's been so successful. And we also have the American group with Ricky Safer's group raising money, and now also we have this other lady whose name I forget, Lisa Boyett. Lisa Boyett, who also is a very driven young woman who's absolutely her mission in life is curing PSC for her brother. So I met him as well. He's a nice chap, a bit bemused about it all, I think. But anyway, he was. But anyway, so that looks exciting. So that's another thing that's happening. And she's looking to facilitate research and raise money. So these just I just thought you some of. I think there are about the reds are in study. I think there's about 6, about to be seven drugs in trial, about to be in trial in PSC. There's the Norurso trial, which some of you may be in. This is a new bile acid, looks very exciting. No liver biopsy in that. There's a beta-cholic acid, which has been shown to be useful in PBC, as about to start a trial. This is a trial in progress. So Tuzovab, which is a study which affects fibrosis it's a biological against fibrosis. There's a very good successful this drug. It should be in red actually. Tuzovab, which is used effectively in Crohn's disease and inflammatory and ulcerative colitis. A very large study about to start through Takeda for that through worldwide. And both these, surprisingly, have gone straight to what's called a phase 3 study, somewhat against our advice, but these are very rich drug companies, and rather than do pilot studies to show the drugs may work, they've gone straight to huge studies to see multinational studies. So these are just about to start or have started already. Again, liver biopsy is involved in that as well. And again, in America, people are looking at vancomycin antibiotic, which I think has interest. Again, going back to the bacteria in the colon, and also rifaximin, which is another agent which affects the biome as well. So this is exciting times, and these are all look very useful. I won't talk about Nora, so that's enough. So basically, before Kate tells you about what she would like to tell you about, you might say that in 40 years we've gone from the screen. This is the famous Munch painting from I think to that. But all I would say was watch this space. I think it's very likely that in the next. I'm sure not very likely. I'm sure that in the next 10 years is going to be a golden period for research into the cause and the treatment of PSC. So thank you very much.